Okay, yeah. So good evening, everyone. We have a total of 3 cases for today. We have Dr. Kish Mankad as usual as our expert guest panelist, and also we have been joined by Dr. Mahesh Kamte. He is the chief pediatric neurologist at JNMC KLE University Belgaum, and he is one of the prime reasons that I had started having an interest in pediatric neuroradiology, because I had done my post graduation from Belgaum. So with that, we'll start off with our first case. This is case 1. I'm not sure if Keith is there, but I'll just go through the clinical presentation. It's an 8-month boy with 3rd-degree consanguinity. Initially had motor delay. Neck holding was attained, but there was no rollover. Then regression for since 7 months of age. Lost social smile and recognition of mother, and was irritable most of the time. There was increased stiffening of the limbs. On examination, there was excessive status, normal head circumference, severe dystonia, no neck control, no weight bearing, and no fixing or tracking. No excessive mongoloid spots, normal hair, no coarse facies, no hepatosplenomegaly. Fundoscopic review demonstrated no cherry red spots or retinitis pigmentosa. Venous blood gas, lactate, and ammonia were normal. At this point, the child got an MRI scan done. And here we have the MR at the age of 8 months. On top is the T2 weighted axal sequences, and you can appreciate these confluent cerebral white matter changes with interspersed linear areas of myelin sparing zones. The white matter abnormalities also extend up to the pyramidal tracts, and you can probably appreciate slight darkening of the ventrolateral thalamus. The pons also demonstrates these abnormal linear hyperintensities, and the cerebellar white matter, the hilus and the peridentate white matter demonstrates these white matter changes with again areas of linear or circular areas of sparing of the white matter changes. On the T1 weighted sequences, you can appreciate the myelin sparing zones demonstrate the slight T1 hyperintensities. Again, the T2 hypointense region corresponds with a T2 slightly hyperintense area. The optic chiasm of the optic nerves demonstrate a slightly bulky appearance. On the diffusion weighted sequences, there was no abnormality. SWI did not demonstrate any areas of susceptibility. At this point, based on the imaging, we can think of the demyelinating spectrum of disorders belonging primarily to the lysosomal storage disorders. So the pattern is known as the tigroid pattern, which can be seen in lysosomal storage disorders, commonly in MLD, Krabbe's, and also gangliosidosis. The dark thalami, though not as very prominent in our case, but it was there in the ventrolateral thalami, can be seen again in the lysosomal storage disorders. The optic nerve thickening is commonly seen in Krabbe's, but also can be seen in MLD. The dentate nucleus changes, as we have seen in our previous sessions, these are the various differentials for the dentate nucleus changes. The more uniform dentate nucleus changes, as seen in the top panel, you have this T2 hyperintensities uniformly involving the dentate nuclei in glutamic aciduria, mitochondrial disorders, L2 hydroxyglutamic aciduria, and NF1. Whereas a more heterogeneous appearance of the dentate nucleus with sparing of the capsules and involvement of the peridentate white matter can be seen in muscular dystrophies, LCH, Krabbe's, CTX, giant axonal neuropathy, and also few case reports have demonstrated that in MLD. So based on the imaging findings, the first possible differential would be Krabbe's and other lysosomal storage disorders.
The dentate nuclear involvement, in the Yeast syndrome as well, you get the dentate nuclear involvement, isn't it, Dr. Kish?
Yeah, mitochondria.
Although it doesn't fit the phenotype here, just a dentate nuclear involvement, that's another condition which should be considered other than mitochondria. Yeah.
But they usually show some areas of restricted diffusion, no, Dr. Lokesh. You were saying Lee syndrome.
Yeast
and
syndrome,
this, yeah. They usually associate with some restricted diffusion.
Do they always show restricted diffusion?
Yeah, there is some differential pattern of restricted diffusion. Though not all the areas might show, but some areas might show. And this tigroid pattern is not very common for mitochondrial or Lee syndrome, and sparing of the basal ganglia or dorsal striatum again.
No, I was talking of yeast syndrome.
Yeast, yeast. Sorry, I got confused. I thought Lee syndrome.
Just for the cerebellar dentate nuclear involvement, because they also have one of the difference. Okay, sure. Thank you.
Anything to add, Dr. Kamte or Dr. Pankaj?
No, this is straightforward Krabbe's, right? I think there might be some mineralization on that susceptibility, which won't be out with the diagnosis.
Yeah.
Just on the edges, it's a bit dark.
Okay.
How is the corpus callosum in this, Nihaal? Corpus callosum?
It appears slightly thin out for a 8-month child, not completely developed, but yeah, okay. It's slightly thin out. Even the brainstem, I think there is some reduction in the volume of the pons.
So, question for everyone: if this is Krabbe's, which is what we think it is, what is the pathological basis of this problem?
Kesh?
I'm actually going back to the Vandernaam-Bugiani paper, and where does kind of the lysosomal storage disorders fall at this point in time?
They have described it in demyelination.
Exactly. So, do you all agree that this is frankly demyelinating in nature?
I think you're pointing towards, is it a demyelination or a dysmyelination? If I'm not right. I'm not mistaken.
No, I'm not actually. I'm just trying to ask people what is exactly going on in the brain. We are very good at pattern recognition, but why is this showing what it is showing? Because it is a storage disorder, right? I mean, we can understand the thalamic signal, and in the storage disorders, the thalamic signal can be quite heterogeneous. We can understand the white matter changes as well as the bulkiness of the optic. And if you had shown the cauda equina, you might have picked up cauda equina root enhancement as well. Yeah. This is just a question to think about, and I'm not challenging any differential there, but the spectrum of demyelination is so expansive now that it's hard to be sure on imaging, particularly as to what is going on at a pathological basis.
Okay. All right. We'll have a look about that and move on to our next case. Again, this was from Kirti. Kirti, are you there?
Yes, I could join, sir. Yes.
Yeah. Okay.
So this was a 15-month boy, was born of second-degree consanguinity with predominantly cognitive more than motor delay. It was so his main chief complaint was developmental delay, and he had come for that. With a normal perinatal history with birth weight of 3.5 kg, and he had no significant perinatal insult at that time. And on examination, had head circumference of 43.5, central hypotonia. So the MRI was being reported with a perinatal insult, but he didn't have an history to corroborate for that. So the main question was whether it is acquired or genetic.
Okay. No siblings, right? Only child.
No sibling. This was the first child.
So here we have the MR images and the T2 weighted sequences for a 15-month-old child. There is slight delay in myelination, especially in the posterior regions, and also there is reduced white matter volume. The corpus callosum is also thinned out, but there is the middle portion and the anterior segments are more thinned as compared to the splenium. To also see the morphology of the brainstem, at least to me, appears abnormal. So also overall reduction of the cerebral white matter volume, no cortical malformations, thin corpus callosum, slightly dysmorphic brainstem, no areas of susceptibility on the SWI. Spine was done. I'm not sure why the spine was done, but I cannot appreciate any abnormalities on the spine. So this is, I think, question of is it a PVL or a PVL mimic? See, it was a term child with no birth asphyxia, so that does not rule out a sentinel event. This is how a PVL appears. The ventricles are slightly prominent. They are scarred. There is reduction of white matter. The corpus callosum is reduced, though there is a posterior to anterior gradient, whereas in ours, the corpus callosum is diffusely reduced more around the anterior segments. The brainstem also was slightly abnormal, at least to me. And there's also some areas of delayed myelination. So based on this, I would think of more of a PVL mimic than a PVL or antenatal injury. This time I'll open the case for panel discussion.
Can you go back to the story, please? Is the neurology progressive or stagnant? Central hypotonia is a very strong genetic phenotype, isn't it? If the clinicians agree with me.
It was a static course, sir. There was no deterioration or neuroregression. There was not. It was not there. It was a static course.
But you wouldn't get central hypotonia with PVL in itself, right? So I think Nihaal is on the right tracks, but which mimic is the question, right?
Any spasticity, KP?
No spasticity, sir. More of hypo.
Yeah, I think the hypotonia, even sort of 1 year plus now 15 months, isn't it?
Yes, sir.
Yeah, so some degree of peripheral hypertonia spasticity would be seen. Less than 1 year, sometimes it might be a challenge, but they start developing that in most of the perinatally acquired spastic type PGS, which is a PVL, there's a etiology. If it is not seen with the absence of history and the consanguineous family, I think as Dr. Nihaal suggested, looks like a sort of a PVL mimic. But radiologically, when we are looking at these images, are there handles, particular handles which will say, yes, this is more likely to be PVL mimic apart from the history and the examination?
Couple of things. I think the corpus callosum dysmorphism here is very strongly genetic in nature. And I think these are thick slices. We might be missing a subtle malformation of frontal development as well. Don't quite know what's happening around the frontal horns, for instance. On the second picture there, for instance, Nihaal, if you, oh, hi Sanjay, good to see you as well. Please support me in this, but I think we might be having a subtle malformation of the frontal lobe as well. The gyral pattern is not correct even on the T1 weighted images, which I think are thick slices. And that would explain why the corpus callosum is so bad anteriorly formed.
Yeah, sorry. Hi, guys.
Mutation-wise, I think we can't suggest a panel from our perspective. I think a cortical malformation panel itself might not pick up. You've got the FOX genes, which can do that as well. So it's quite a spectrum now, isn't it, for the frontal underdevelopment genes?
And also, Kesh, I think the occipital lobes, you look at the cortex there, it's not, you can't really define it all that well. If you look in both the T2 and T1 weighted images, there might be a little bit more like the malformation there. And also, I don't like the insular abnormalities as well. It looks like almost it's bright. I can't tell, there's thick slices. Also, the sagittals, if you look, there's a little cyst-like thing in the corpus callosum. It looks like a malformation rather than acquired pathology. So I think the genetic would be number one up in, at least in the radiological sense.
Yes, and I think none of our PVL mimics also will be satisfied here. This is a malformation until proven otherwise.
Okay, if there are no further comments, Kirti, I hope we can get a genetic result for the patient.
Yes, sir. I'll send, sir. Thank you very much.
Okay. Right,
Kirti,
thank you.
can I ask you a question? What genetic test would you do? Would you do a triome or would you do a clinical exome?
I'll go for an whole exome, I guess.
Okay.
Okay, next case is from Dr. Kavita. Sahil, are you there? Want to present the case?
Yes, sir.
Yeah. Go ahead.
So this child is, yes, sir. So this child is a 17-year-old female, born of second issue of non-consanguineous marriage with normal perinatal and developmental history with negative family history. So she presented to us with fever since 4 days, followed by altered sensorium like drowsiness, irrelevant talk, and lots of confusion. So on admission, the GCS was definitely 12/15 with there was no other neuro deficit as such. So the possibility of encephalitis was kept, and the workup was done, which was everything was normal. We had done her CSF workup, CSF biofire workup, which turned out to be normal, and then we did an MRI of the child. Yeah, the CSF workup, which was showing completely normal, the biofire was negative, and electrolytes were normal with a good KFT and LFT. COVID antibody was also negative. So we did the MRI in this child at the initial admission. So it was.
So we have 3 sets of MRI. This case was discussed, I think, a couple of months back. if you remember the case. So here this was done in September 21. So these are actually images from films, but you can appreciate the asymmetric layers of restricted diffusion in the ventral brainstem, also in the hippocampus, but they do not correspond to low signals on the ADC. Similarly, on the FLAIR images, if you appreciate on the coronal sequences, you have these hyperintense mesial temporal lobes and also the midbrain. There are no other abnormalities, especially in the supratentorial brain parenchyma. The deep brain nuclei also demonstrate normal appearance. Post contrast, there was possibly slightly mild enhancement of the midbrain abnormalities. So at that point, the CSF biopsy was done, and we thought of a possible autoimmune related etiology or a mitochondrial related disorder. And demyelination also was evaluated, and it has come out negative for MOG. So I'll just go on to the next images, and this was again repeated in October. And there you can appreciate again these hyperintense changes, but they are not acute. They are residual hyperintense changes in the midbrain. There's development of a new hyperintense foci in the right side of the midbrain. No acute abnormalities on the DWI. The spinal cord was imaged and it was reported normal, but you could appreciate there was a small focal segmental abnormality along the anterior segment in the lumbar region. And this is the most recent scan. No abnormalities on diffusion. Again, these hyperintense foci, tiny foci in the midbrain. There's also residual hyperintensities and slight atrophy of the bilateral mesial temporal lobes. T2-weighted sequences of this sagittal spine. I could not appreciate any abnormality. These are likely motion-related artifacts. As you can see, the lines are also evident in the vertebral bodies and also in the prevertebral region. A possible cystic lesion over here, but we did not have axial cuts. And we previously discussed the possibilities of autoimmune encephalitis. Also maybe a rhomboencephalitis. So I think the diagnosis is not certain, or we don't have a confirmed diagnosis now. So I'll open the case for the panelists for discussion.
How did we read that CSF?
Negative.
Sir, one
CSF
thing we wanted from the I'll go ahead. Yeah. So one thing we wanted to know, the child later presented to us with after the MRI, we suspected limbic encephalitis, and later on the child had lower limb, right lower limb dorsiflexion issue, foot drop, and the power had a neurodeficit of power of 1/5 on discharge. And following by that, high stepping gait was done. So subsequently, the child is coming to us for follow-up, but still the power has not improved yet. And the subsequent spinal screening which we had done, which was also normal. So what is the possible explanation? We wanted to know.
Most of our autoimmune encephalitic workup that we have looked at a cohort recently were actually antibody negative in children. So you may never find anything if you're going to label this as autoimmune. Yeah, if you leave it on that slide, so all these are various possibilities, but you don't always find an antibody, and I'm sure your experience might be similar out there. I can't at the moment think of a differential to these appearances, and at least the way things have evolved.
And that list is incomplete because we have many more antibodies coming in every single day. So I think that list you have to consider as incomplete. So it's imaging wise, the way that the bilateral hippocampal abnormalities, the atrophy that you see on the follow-up imaging, and the new lesions you see, those still fit the limbic encephalitis picture and autoimmune encephalitis picture. And like Kish said, if you don't find an antibody right now, you still have to treat it as one, because that's the most likely diagnosis. And there's a panel that is expanding every single day. We have like pretty much every single day somebody adds a new antibody to that list.
I also don't think we test for all the panels here in India. Dr. Kamta, Dr. Lokesh, do you want to add on that?
Usually we test only for NMDR and VJKC, and MOG and NMO. These are commonly tested. Only one lab in India does GABA. That's also like not totally done. So,
okay.
Nihaal, question for you. What was the cerebellum looking like on follow-up?
Normal.
Is that the follow-up?
Yeah, that's the follow-up.
Okay. We picked up a higher incidence of cerebellar atrophy in our population with the autoimmune, but maybe it's a downstream effect.
And also, Kish, I think the factor of steroids are playing in, and the treatment can also cause the cerebellum to look atrophy. So always have that in caution, and it might be a treatment effect as well.
Sure. Isolated cerebellar atrophy in steroids without brain?
No, I mean, if you have both atrophy, like here you have the hippocampus is atrophied, but the rest of the brain is preserved. So I get it. If there was atrophy here, I'd be worried. But when you usually see cerebral atrophy, you might see some cerebral atrophy, and those ones I always like question whether the kid has had steroids recently, and then trying to correlate with them. But what's interesting is there's no history of seizures. I noticed that the first slide said no seizures and yet hippocampal changes, but the sensorium is altered. So it might be just a temporal lobe involvement from that. And there are no axials to the cauda equina because radiculopathy was seen. I didn't see any axial images to see if there's any.
No, they just did sagittal. They didn't do an axial.
Yeah, there was an enhancement. Okay.
Okay, sir. Thank you. Thank you.
Right. Okay, thank you. Just clinically, anything to rule out, Dr. Kamte or Dr. Lokesh, regarding the ankle clonus, right ankle dorsiflexion, right stepping gait?
No, I think there are some midbrain lesions, probably if there are asymmetric, that might be causing it. But overall, I think still with all the armamentarium what we have, although the Californian project said the 30% diagnostic rate in the encephalitis, it is probably slightly better as compared to earlier, but we still have a large chunk of patients where we don't get a etiology cancer in the acute encephalopathy. That's still a challenge there to be solved.
Okay, thank you.
Hello.
Yeah, please go ahead.
Just one point. Can we consider lupus for this child, considering she's a girl, 17-year-old? She has peripheral plus radiculopathy, CNS involvement. Although an acute presentation, probably it may be worthwhile, I don't know, working up for lupus also. With an odd presentation does not really giving answers in anything else.
Like clinically, definitely needs to be evaluated, Dr. Kavita, irrespective of this one, with this kind of presentations and the age especially. Definitely need to evaluate for SLE, CNS vasculitis.
Yes, sir. She doesn't have skin rash or other features, but yeah. Okay.
Yeah.
Okay.
Initially, isolated CNS lupus can present initially. Later on, they can evolve to other features.
Yes, sir.
So, but I think we should start. Definitely, when you don't have a diagnosis, otherwise, you should.
Okay.
Okay, right. Thank you. Next case is from Dr. Ramesh. If Surbi is there, or
Yes, I'm here.
okay, yeah, go ahead.
So this was a child. He was a 11-year-old boy, and he had presented with one episode of seizure, which was more of a non-motor seizure, and it was a status. It was some deviation of the eyes to one side and unresponsiveness for about 15-20 minutes. And he had some vomiting during that episode, and then after that he had an irritability and altered sensorium for 2-3 days. Following which the child became normal. He recovered back to the normal status. And for this episode, he was admitted and given some medications. We're not very sure whether he was given any steroids, but he was given some antibiotics. And now it has been almost 1 year after the episode. The child had no recurrence, did not have any focal deficits or any other issues. For that episode, there was a CSF done which showed what is shown here, the protein 20, sugar 60, and cells, there was mild phagocytosis with lymphocyte predominance, and COVID was negative. So the question for the imaging was whether it is some form of viral encephalitis or it is a demyelination-like picture. Because at that time there were no other sequences done, and now also the child does not have any deficit, but just the prior imaging was little doubtful.
Any clue on the CSF, Surabhi? Does it point towards a viral etiology?
They did not, like the PCRs was sent and it was negative is what the parents told, but we did not see those reports. Most probably it would have been negative.
Okay. So these are again taken from an external film. They might be slightly distorted. If you can see on the top panel, you have the FLAIR images. There are some areas of hyperintensities in the bilateral frontal lobes and also in the cingulate region. Some patchy areas of hyperintensities in the left basal ganglia and possibly in the thalamus, but I'm not very certain of that. No abnormalities in the brainstem or the cerebellum. T2-weighted sequences again demonstrate this patchy hyperintensity in the left anterior putamen and also in the perinsular region. I did not have an ADC sequence along with in the films, but these areas appear slightly brighter than the other rest of the brain, especially in the bilateral frontal regions and possibly in the cingulate region. I'm not sure if this is an artifact. If you can observe over here in the anterior cingulate region over here and also over here in the right frontal region. There's also some slight hyperintensity on the EDWI in the left basal ganglia lesion. So at this point, thinking of differentials of demyelination, possibly MOG antibody-related disorders, and also infective etiology, viral infection would be the first possibility as compared to other bacterial and fungal infections. And I'll open the case for the panelists.
And if you went back to the history, please.
So can I ask a quick question about the imaging? Go back to the hippocampus and look at the temporal lobes on those axials. Is there some increased signal there on the axial images? I don't have a coronal, so.
Yeah, I think the temporals are involved as well. You're right.
Bilateral temporal lobes are involved. Encephalitis would be number one. In the acute setting, you only have one seizure etiology, one seizure presentation, vomiting, lethargy, would be very encephalitis-like presentation. Of course, if you had a prior episode was not diagnosed before, or they had like mild symptoms, then you would think of the other etiologies. But demyelination should be number two. But I think in the setting of that clinical setting that you had, encephalitis would be number one. And there was no PCR on that CSF either. I think it just
no.
Else.
Yeah, just CSF normal basic.
Right. So that would be number one and two. And the fact that there's no motor deficits and there's nothing, no recurrence of seizures, again speaks to something which was a single process which is improved after initial treatment. So at least in imaging, and I think also on if you look at the basal ganglia, the thing you're showing in the basal ganglia actually goes a little bit more laterally on the external capsule.
Yeah,
almost,
it goes, yeah.
Right. So I think there's cortical involvement here, and those gyri look swollen as well. If you look at the frontal lobes, there's some swelling of the gyri.
Yeah.
Either from seizures or not, but either way, I think encephalitis would be number one in my differential here.
I would have a low threshold to exclude MOG here.
I think you did say there was anti-MOG was negative, right? Or was that?
No, they haven't. The
No,
COVID
they
was.
did not send any panels for NME.
Is
there a vermin atrophy there? Sorry. Is there a little bit of vermin atrophy on T2-weighted images?
Yeah, they are prominent, I would agree. Yeah.
No, it's normal for 12. By the age of around 9 or 10, you start seeing the cerebellofolia quite clearly, actually, and sometimes misinterpreted as atrophy. It's a pitfall. I think the brain has just managed to expand into the cranial space quite well by that age.
That last
But the phenotype is very typical for MOG to have deep gray as well as cortical involvement, and then everything getting better, almost like an ADAM-like presentation without any antecedent pyrexia or prodrome. Vivek, you're not saying much today. Please challenge me, but I would exclude MOG early on in this case.
Yeah, Mog
JA
is
Japanese.
important.
Is
Yeah, Dr.
JA
Kamble.
possibly Japanese encephalitis with the thalamic involvement?
Not the pattern for Japanese encephalitis. We say never in radiology, but not the pattern for it.
It's just that the diffusion restriction is not as prominent as the T2 hyperintensity, which makes you think this must be more inflammatory rather than cytotoxic like encephalitis. So more like a dysmyelination. So more like anti-MOG should be ruled out. Yeah.
But if there are
There
no
was
symptoms,
sorry.
if there are no symptoms, would you still investigate now? The kid's actually fine, right? Is that the case?
The problem with
Would
MOG is
you-
the recurrent ADEM-like presentations they have. So, I mean, if there is resource, it will be good to baseline it. At least you know what's happening if it comes back.
Fair enough.
If you think of MOG, I think of MOG encephalitis. No? Then the outcome is very bad in MOG encephalitis. The clinical outcome is very bad in MOG encephalitis.
Not always, right?
Mahesh, I will disagree with that because actually it is one of the better encephalitis, autoimmune encephalitis to have. It's just maybe it's the patient population which might be different, because if I had few, they've recovered really well. There's only one who is bad, I will say. So it's not always bad.
Okay.
Okay, if there are no further comments,
just there I will mention the thing which we have observed, this anti-GFAP astrocytopathy, which is not there in this child. Now we have got 3 cases here, and actually that's one of the better ones. Those patients just have one attack and they just recover, and the antibody stays positive, and there's no problem. So among the dysmyelination, if God tells me you have to have one, then I will have anti-GFAP astrocytopathy. So that's the one we have observed, better than even MOG.
Vivek, it will be great to see your 3 cases together if you can next time, if not this time.
Sure. So yeah. So 2 of them are mine, and 1 is from my colleague from Brisbane. So I'm not sure. I'll share my 2 cases. Yeah.
okay, thank you. We will move on to our next case. Yeah. Surbi, you can take over.
Yes. So this is a 4-year-old boy. So this history started almost 2 months back when he came with a febrile illness, and then he had some analgesics and antibiotics, and that precipitated some hematuria and led to acute kidney injury. The child came with it's almost like a hemolytic uremic syndrome like picture, or autoimmune hemolytic anemia like picture. So this child was started on plasmapheresis for the AKI, and then almost on the 4th cycle he developed an hypertensive emergency and had a seizure, for which he treated with antiepileptics. He recovered, but then on the next cycle he had a cardiopulmonary arrest and he required a CPR for almost 20-25 minutes, and then had the return of spontaneous circulation after that. And in view of persistent encephalopathy, we did the imaging that time, which showed features suggestive of atypical press. So we treated the child with antihypertensives, and gradually the systemic manifestations improved and the hypertension also improved, but the encephalopathy persisted. So almost like 2 weeks later also, the child was still having a significant neurogenic stridor. He was opening eyes only to stimuli, and he was having extensive posturing. So we redid the imaging to look for any new changes in the brainstem or any other new lesions, but the previous lesions had resolved, and there was almost complete resolution of the changes which were seen in the previous imaging, but there were some new changes in the form of globus pallidi hyperintensity, which was symmetrical. So we were not able to explain those changes, and also the persistent encephalopathy. For that, we did send some metabolic workup also in the form of TMS and serum homocysteine and ammonia levels, which were all normal. The systemic markers are absolutely normal now, but the child is still encephalopathic. There is very minimal improvement in the sense that he's having spontaneous eye opening now. The hemodynamics are stable, and he's having some spontaneous limb movements. That's it. He's still on NG feeds, and there is no vocalization still. So yeah, that was the question, the reason for those changes and probable etiology, if any. Also in the background, this child had some speech delay with hyperactivity, but not so much of impaired communication. So the autistic features, whether they were there or not is plus minus, but otherwise no significant developmental or perinatal history or any family history.
Okay, thank you, Subi. So these are the first set of images in February 7th. And on the flared sequences, you can appreciate these focal cortical subcortical areas of hyperintensities in the right frontal region, also involving the parietal white matter. If you come lower down, you can appreciate that there is also involvement of the basal ganglia on both sides, more on the right, and also the internal capsule. The splenium of the corpus callosum also demonstrates this hyperintense change, and there are some periventricular hyperintensities in the occipital lobe. Coming more inferiorly, the brainstem also demonstrates hyperintense changes, and there are more symmetrical pattern of hyperintensities involving the bilateral cerebellar hemispheres. And coming lower down, you can appreciate that there is some inflammatory or edematous change in the suboccipital region involving the suboccipital muscles. On diffusion, none of the hyperintensities demonstrated any restricted diffusion. T1 weighted sequences of the corresponding hyperintensities demonstrated iso to hypointense areas of hyperintense changes, and there's also some degree of generalized cortical cerebral atrophy. On the SWI sequences, you can appreciate multiple microhemorrhagic foci involving the bilateral cerebral hemispheres. The white and gray matter is involved. The central white matter is involved. The corpus callosum also demonstrates these microhemorrhagic foci. The posterior fossa, you can appreciate tiny foci in the middle cerebral peduncles and the lower aspect of the brainstem. There are no edematous changes in the optic nerves. The follow-up scan, you can appreciate symmetrical areas of restricted diffusion involving the bilateral globus pallidi and also the midbrain, the substantia nigra. The hyperintense foci as seen in the previous scan demonstrated almost there was a significant reduction in the hyperintense changes. The right frontal is almost not evident. There's some patchy residual area of hyperintensity. The basal ganglia lesion, especially the anterior aspect, are resolved, but there are new changes in the posterior putamen. Possibly in the bilateral thalamus also demonstrates slightly hyperintense changes, and also the brainstem has the residual foci of hyperintensities. The corpus callosum is thinned out with a generalized reduction in the brain volume, and also the midbrain also demonstrates reduced volumes. The microhemorrhagic foci also are again seen on the present study. Spectroscopy was done in the deep brain nuclei. I cannot appreciate any diagnostic peaks, at least to my knowledge. So at that time, we thought of a possibility of breast given the renal abnormalities and also the presentation of hypertension. Microangiopathy, as seen in the cases, is known to be a risk factor given the coagulation abnormalities and the hypertensive risk factor. Again, these are just a selection of possibilities for non-traumatic hemorrhagic foci given the hematological abnormality in our child. And just to cover up the symmetrical changes, especially in the globus pallidi, though they were not seen in the first case, I would think it would be less likely for a inherited disorder, but these are the differentials for bilateral globus pallidi changes. I also thought of a possibility of a CNS vasculitis if it needs to be considered given the renal issues. And also COVID is also known to be presenting with these changes in the brain parenchyma and also associated with the microhemorrhagic foci. So inflammatory changes also demonstrated in the known COVID ischemic inflammatory changes. And at this point, I'll open the case for further discussion.
In view of the severe neurology, is there any evidence of that severe hypoxic event and the cardiopulmonary resuscitation affecting the brain seen on the second image, although not acute response? So that might explain the neurology.
Do you think it is ischemia necrosis going on there? But the involvement of globus pallidus more than the dorsal putamen was slightly atypical, as commonly seen in hypoxic insult.
But do you think the posterior putamen is also involved? If you look at that axial image there, the flare, the posterior putamen is involved.
Yeah.
Right, thalamus is involved. So if you just had that image and you cover up the cortex and just look at that area, that's more like hypoxic injury. And whether there's underlying mitochondrial disorder or something which is predisposing is possible. but the press makes more sense for the microangiopathy and the microhemorrhages. And I think it's a superimposed second event of the cardiopulmonary arrest that you had in the history might explain the long-lasting features. Also, cerebellar involvement is interesting. We have seen a very almost a cerebellar only press events, and these can be life-threatening emergencies because the cerebellum can swell and you can have herniation. So that cerebellar involvement, the microangiopathy, that all fits with the press, and this is probably a secondary event here, which is, I agree that it's more likely a hypoxic event. Also, if you look at the first MRI, wonder if the basal ganglia is small to begin with, kind of abnormal to begin with. I don't know how many days after the first event this was, but the volume of that basal ganglia itself looks a bit funky. You just look at both the caudate, looks brighter too, right? It's not normal.
Yeah, it looks bright.
The first scan was immediately like the next day after that CPR, the arrest, and the later imaging was 2 weeks later, and this was like first week into the illness, the first imaging.
Dr. Survi, was there any evidence of intravascular hemolysis, like for TTP?
There were schizocytes, but not very significant. And the HUS, actually, they had set a genetic panel also for HUS, which turned out to be negative. So they were thinking of
HUS genetic panel. HUS genetic panel, is that?
Yes, yes,
okay.
Sir.
Okay. So, but that doesn't rule out HUS TTP, even if is it something? Tell us about it. This
My
because
primary
so this is
HUS. You're right.
Yeah, because this looks like HUS TTP spectrum.
No, I didn't know about a genetic panel for HUS. By the way, that's
that's new.
The cerebellar changes, the oncoming basal ganglia changes, the microhemorrhagic change. It's all compatible with that. So the question is, can a genetic panel exclude HUS? I didn't know that, but I'm happy to be wrong. I guess everyone is thinking that way.
I'll just add a comment. I think the HUS panel is sometimes sent to look for certain genetic polymorphisms like ADAM-TS11 or something, which may be causing the HUS thing. But I think per se in HUS diagnosis, we do not need a genetic thing, a genetic testing. That is what my understanding. It might be very, very limited, I think. But I think in one of cases, in case it is an atypical HUS or something, then they end up sending for these ADAM-TS11 levels or a genetic cause for that.
Also, genetic complement deficiencies, H&I.
Yeah. Yes.
Is it like A&E? Like if sometimes you have A&E, so you have RAN BP. So similar in HUS, is it? Same sort of concept. So maybe some could be genetically predisposed. Some.
Yes, sir. Some can be genetically predisposed. Some may not be. So probably that was the reason for sending.
Thanks.
And Nihaal, on your MRS, the only thing you see is the NA is reduced in that area that you have the voxel. It's not completely normal because NA is kind of reduced. Not actually changes anything. And also noisy baseline, so can't really feel lactate, but doesn't look like it's lactate.
Yeah. Okay.
Last question. The first imaging did not show any changes of hypoxia because we did the scan too soon, like almost next day we did, and that's why we didn't see any hypoxic ischemic changes in that, and only the press changes.
So there was no cardiorespiratory arrest after the first scan?
There was a cardiorespiratory arrest, and the next day we did the scan.
The first scan or the second scan?
First scan, sir.
And nothing in between from the first to second?
No, sir.
It's interesting, isn't it? Because there's a few hours at least after your event. It's 25 minutes, and you should see at least something mild.
Yeah.
I have
Yeah.
cases where
That's
you see some very mild changes, and this one, the diffusion looks pretty normal. I mean, you can't
Yeah.
call the diffusion abnormal in any way. So the cerebellum looks abnormal, but there is no basal ganglia or thalamic changes. Interesting. That doesn't fit very well, but I've seen at least one case where we have a witnessed arrest for about 12 hours later, we had a normalish looking scan. 24 hours later, we had a mildly abnormal scan. And then after maybe 36 hours, we could actually see abnormalities. This kid actually had arrest in the hospital to actually time the whole event. And it's a very recent case. So it is possible that you're not seeing it. And if you look at that FLAIR image, there's some bright signal there in the basal ganglia, in addition to those patchy areas. And if you go back to diffusion, I would like to see the ADC map a little, but the basal ganglia has a very mild change. Look at the caudate and the putamen. Can't really tell. You probably need to look at the ADC, but you can be very, very mild early on. But I do agree, for 25 minutes arrest, you see very little here.
So
What is the age of the child, Surbhi? What is the age of the
4 years
child?
old, 4-year-old boy.
4 year. So correct me if I'm wrong. Actually, it's the radiologist domain, but I'm saying sort of what I have seen in the first 18 months. So if between 6 to 18 months, if you have hypoxia, you see these changes, the midbrain, the thalamic, the globus. And surprisingly, after 2 years, if you have hypoxia, you tend to see more of a significant basal ganglion. So you're more like putamen, globus, swollen, thalamus, swollen. But the patients, my patients, few of them, what I have observed, if they had hypoxic event before 18 months, then you see these changes. After 18 months, the changes are different. They are not these changes. These are more in a, so if you had a child who was less than 1.5 year age, you will see these sites as hypoxic changes, but after 2, you see it more prominently in the basal ganglia. Is that, and cortex? Just an observation. So just related to the myelination, or I don't know, but that's what I have seen. But it's just few patients. So that's
Also
something which is always, yeah. Sorry.
Right, it's activity of the child and what areas are actually more metabolically active, and also the
Sure.
pattern of hypoxia makes a difference. So if you actually put those ages, the pattern of hypoxia, the duration, and all of them together, then yes, there may be certain patterns which exist, but you can't put them exactly in brackets because each case is slightly different in the duration of hypoxia, when you image, etc. But the differences might be related to the metabolic activity at different ages.
Sure.
No, just a question. The cardiorespiratory arrest was on 7th, and the second scan is on 23rd. That's more than 16 days or so. Do you still expect change of vesicular diffusion at 16 if there was no interval sentinel event?
I think the pattern is not typical for that.
Okay. All right.
Isn't
Thank
ADC
you.
almost getting to
Yeah.
normal? Because ADC is not as
Yeah,
low as
yeah.
the diffusion is, right? Maybe
Yeah.
fading away.
One second, Nihaal, what is this child doing or not doing? If they sustain an HIE, you would know clinically by now that they had a hypoxic-ischemic injury, right?
I had a cardiopulmonary arrest during plasmapheresis.
Yes, but what are they doing right now? Are they flat out?
Surbhi?
So the child is hemodynamically stable, is on NGP, is having some spontaneous eye openings, some vocalization, and some spontaneous limb movements. That's it.
And spastic? Any
There
reflexes?
is spasticity in the lower limbs more than the upper limbs. The gastric pneumons have almost gone into contracture. The DTRs are exaggerated with the bilateral ankle clonus.
Yeah.
Okay. If there are no further comments, we'll move on to our next case. Case 6, Dashrath, if you're there, you can present the case. Okay, I'll go ahead. So this is a 9-year-old male child with acute febrile encephalopathy and had vomitings. There was history of similar complaints in the past. The illness started in 2019 and was associated with seizures and treated in the lines of tuberculosis. A second episode of acute febrile encephalopathy with vomitings was encountered in 2020, and at the time ATT was used. So we have a scan at 2020. The images are not optimal, but on the top panel are the diffusion weighted sequences. Really not able to make out any subtle changes, but it appears completely bright. So that is probably related to the film quality. But if you come down to the flare images, there is some areas, patchy areas of multifocal areas of hyperintensities. You see in the right posterior frontal region and also in the left region, the subcortical areas are bright. The temporal lobes also demonstrate some areas of hyperintensities bilaterally, more on the left. If you see it is extending up to the peritrigonal region. There's also a small focus in the left midbrain. The cerebellum otherwise was normal, though I don't have the images. And post-contrast study, there was no enhancement, no parenchymal enhancement or no extraaxial or leptomeningeal pachymeningeal enhancement. The spine T2, again, the image is not ideal, but I cannot appreciate any focal lesions in the spine. So again, this child had a third episode of acute febrile encephalopathy, now presented with right-sided gaze palsy and meningeal signs were positive. The extensive Lancer response demonstrated good response to steroids. CSF had cells of 6, glucose was 60, protein was 57. The culture was negative. AFB and Gram-stain were also negative. Oligoclonal glands was not sent. Serum MOG was sent, which was weakly positive. Dr. Lokesh, whether you want to add anything to it?
Sorry, actually this one child was admitted elsewhere. They just had sent for opinion with both the scans, and the child was encephalopathic, not very severe. He was responding to name call and with the pyramidal signs. Looking at the MRI first and second with diffuse white matter involvement, we thought under recurrent episodes, we thought more of a demyelinating disorder rather than sort of tubercular etiology. So after the consultation, the MOG was sent. So
okay, so I'll just show the recent MR. So here's the MR in 2022, and the lesions have progressed. They're now also involving the cortex. They're more heterogeneous now. If you see on the T2-weighted sequences, they're heterogeneous, hyperintense. They're progressed as compared to the prior study. They're more nodular or focal in appearance. Bilateral cerebral hemispheres are involved, predominantly the white matter. The cerebellum and the brainstem involvement is also progressed. No abnormalities on the diffusion, though the film quality is not ideal, but again, I cannot appreciate any standout bright lesions on the DWA sequences. Contrast, again, there is no contrast enhancement. Possibly there's a small nodule over here in the left frontal region, but other than that, I could not appreciate any abnormal foci of enhancement. So they were treated as TB, but I think tuberculomas usually do enhance. And the appearance is also there's central core of hypointensity rather than the heterogeneous appearance as seen in our case. And I would concur with Dr. Lokesh, probably demyelination, but the second scan is slightly atypical for a demyelination or not. So at this moment, I'll just open the case for possible comments from the panelists.
I mean, demyelination looks like the most likely on the first study, you're right. And the second one, is it some cerebral atrophy there? Go to the side still, please. Is the cerebellum a little on the second scan? There, not really. So just the worm is really hypoplastic.
Yeah, worm is slightly hypoplastic.
Yeah. And there's no steroid use recent prior to the second scan. There's lots of volume loss there.
In a very short admission prior to the second scan. So he was only for 3-4 days in the hospital there, and he was on dexamethasone during that period.
Right, but that doesn't explain the significant amount of volume loss you have here. Almost global, and those white matter changes have become much more confluent, many more lesions. No cortical involvement. Most with subcorticals deep. Not seeing any specific cortical involvement. So still speaks of white matter process. Demyelination is still number one. And like you said, there's no enhancement anywhere either scan. Sometimes with steroids you can mask enhancement, but this one looks like there's no enhancement on both scans. I still think it's in the demyelination category. I don't know what Dr. Kamte thinks.
Yes, I do agree, sir. It looks more like demyelination, mostly MOG associated.
I think the MOG is relevant here, and there are cortical changes, isn't it? In the left parietal, I think we were showing some picture there on the fourth picture. Also, the involvement of the cerebellar peduncles is very typical, and I think the weakly positive MOG might be relevant here.
Yeah, and within a week's time, he was completely normal with the steroids, pulse steroids, unfollowed.
Okay, thank you. So we'll go ahead with demyelination, probably MOG related demyelination as a diagnosis.
So even though this is not classical of GFAP, Lokesh, you should still do GFAP. Why I'm saying that? Because the patient from Brisbane, which I mentioned, had just leptomeningeal involvement, and 2 of my patients who had it, one of them had mildly positive MOG. Then we repeated it after a year, MOG was negative and GFAP was strongly positive. Similar, but MRI images, the white matter involvement in GFAP is very classical, at least in those 2 patients, what was seen. But the story was similar, and the MOG was mildly positive, GFAP strongly positive. So there's no harm in doing GFAP.
Now, in the sense, there you have intense contrast enhancement in most of the GFAP.
That was what I thought. So the Brisbane patient had definite leptomeningeal enhancement, no gray or white matter. So there was no demyelination, no cortical involvement, just leptomeningeal enhancement. One of my patients, so of the 2, one had significant contrast, the third one didn't. So it's just an evolving disorder probably. So it's just because these are the few things we can do. So we can just, and we have it now. So maybe we will learn better if we do it. So the third one didn't have any contrast.
Yeah, sure.
And MOG was mildly positive, and repeat one negative, GFAP positive, strongly positive.
To Vivek, if you have your cases, I have some cases of GFAP that we can probably share as well. I have about 4 cases. Just looking at my numbers here, I have about 4 cases as well.
Sure.
And the enhancement can be a variable. I agree. It can be incomplete to much enhanced. It doesn't always have to enhance. I agree with that.
I think we should put our cases together in a large series if you all are interested. Nihaal can probably connect us.
Okay, we'll do that. If people are interested, they can message me and I can probably send out a common email to everyone. Yeah. Okay, we move on to our next case. The next 3 cases are from Dr. Kamte. Dr. Kamte, do you want to present the cases?
Yeah. This is the first case, which is a 6-year-old boy born to secondary conjunctival married couple, presented with the regression of milestones for the last 6 months. Initially, the reduction in speech output and then poor comprehension also. After a month, he stopped recognizing parents. After 3 months of the onset, he had difficulty in walking and standing. Parents reported jerking of limbs, which were present for the last 3 months, and the vision has worsened in the last 3 months. The elder brother of the child also had similar complaints, and he was almost bedbound now. He had onset at 5 years of age, and now he is 9-year-old. This child had normal birth and early development, had mild microcephaly and examination with no dysmorphism. There was mild spasticity in the limbs and ataxia was present. Fundus examination showed atypical retinitis pigmentosa. And the EEG was done showed generalized irregular spike and sharp waves, along with some multifocal epileptiform discharges. With this picture, with ataxia, myoclonus, and regression affecting both the cognitive and vision, we thought of NCL in this child. Okay, show the images.
Yeah. So we have the images on top. You can appreciate a global diffuse volume loss involving the supratentorial and infratentorial brain parenchyma. If you come down to the flare images, you can appreciate these periventricular hyperintensities and also probably extending up to the subinsular level. The thalamus is also reduced in volume. There are some hypointense areas of the ventrolateral thalami. The cerebellum demonstrates reduction in volume, and if you can probably appreciate the cortex is slightly hyperintense, especially in the inferior cerebellar hemisphere, and also the vermis is slightly hyperintense. You can appreciate the supra and infratentorial volume loss on the coronal images. The corpus callosum also demonstrates reduced volume. The brainstem also is reduced in volume. There was probably no SWA changes on the thalami, though probably some tiny foci are there, but not very significant. Spectroscopy, the Na is slightly reduced and the choline is slightly elevated, if I'm not mistaken. I cannot appreciate any other lactate peaks of the myonistor also is slightly reduced. So given the possible imaging possibilities, at least the approach, given the posterior fossa changes, these are the differentials for cerebellar atrophy with the cortex hyperintensities. NCL is one of the common differentials. And the supratentorial white matter changes, especially the periventricular subinsular involvement, the dark thalami, and the global volume loss is well described in the neurocerebral lipofuscinosis. This is a paper from the sick kids. Differentials can be many, especially when we encounter the child in the burnt out phase or the chronic stage, but these are the common differentials, possibly to be ruled out given the global volume loss. Pyridinase, vitamin B12 deficiency, mitochondrial disorders, and rapopathies. Retinitis pigmentosa was seen in the case, and these are the common differentials. Lysosomal storage, lipid disorders, and mitochondrial disorders are common for retinitis pigmentosa. Dr. Kamti, do we have the final diagnosis, the subtype?
Yeah, the elder siblings MR also showed the similar features, and we have done genetics for this child, whole exome, which revealed a likely pathogenic mutation in CLN8 gene. So it's a case of NCL type 8.
Okay, is that the only subtype with retinopathy or retinitis pigmentosa?
No. Retinopathy in many other types also. It's many other type 2. Nihaal, I wanted you to comment on the baseline changes in this child, baseline, along with thalamus. What about how is the putamen?
It is slightly reduced in volume, maybe slightly hyperintense, but
is the hypointensity in the putamen?
I think it's fine.
That's the globus pallidi. Yeah, the putamen is
on the third image.
Yeah.
That's what you're asking. The perivascular spaces in that third image. There doesn't look like.
They are perivascular spaces along the antecommissure. Yeah.
I think the putamen is fine.
Yeah, it's fine.
GP, globus pallidus.
What is the age again?
Age of the child? 6 years.
This child is 6 years now. 6 years.
Yeah, that's fine too.
Okay.
As much as one can tell from these two images.
Yeah.
And again, the Na is reduced in both your MRSs. The Na and choline almost equal, and that's it goes with Na. And you can follow serially on NCL cases, and you'll see the Na fall in the same area if you do serial imaging. The only other differential which is not included in your list is I have seen an interesting case of myoclonic epilepsy with retinitis pigmentosa and leukencephalopathy. I saw this a few years back, and that can present with changes and also can have calcifications. So that would be differential as well to consider. But NCL makes sense.
Okay. Okay, then we'll move on to our next case. Dr. Kamte?
Yeah. This is a 1-year-old girl who went with regression of milestones, irritability, and excessive crying for the last 3 months. She also had tremor-like movements in both the fingers, fingers of both hands for the last 2 weeks. There is no frank generalized tonic seizures or any myoclonic jerks. There is history of reduced feeding, and there is no history of any diminished vision or hearing. On examination, child had microcephaly. There were fine continuous tremors affecting the fingers of both the hands and even in the foot also. The tongue was not involved in this child. Child had pallor with hyperpigmented knuckles. So we had thought of vitamin B12 deficiency, and we did labs like we showed anemia with macrocytosis, research of again vitamin B12 deficiency. The only problem here was this child was given vitamin B12 and was sent home after 2 weeks, but child got admitted again after 2 weeks with continuous jerking in the left hand, for which child was admitted elsewhere and was managed as a case of status epilepticus with IV anti-epileptic drugs and even that repeated vitamin K, vitamin B12. But despite that, this jerking of the left upper limb continued for more than 2 weeks. So just want to know, is there anything else other than vitamin B12 deficiency in this child? Okay, show the images.
The urine GCMS, yeah, the urine GCMS is not significant. Elevated.
TMS was negative, and the urine GCMS was very non-specific.
Okay.
What was the homocysteine?
Homocysteine was around was normal, Vivek. It's around 28, 24, not very high.
So that was but after injection, right? So you already received injection.
Yeah. Even vitamin B12, when we did, what was around 384. But many of these patients do receive some oral supplements or elsewhere before the presenting. So
because it's still high, because it looks like infantile tremor syndrome.
Yeah,
because they have it.
Only thing, yeah. After treatment, after about 4 weeks, child again had this continuous jerking of the left hand, only the left hand actually. So that was very atypical.
So it's you do see it, not commonly, but it's something like EPC. You feel it is EPC, but it is not EPC, and it's and it just resolves. And one of my patients, it took 3 months. So we don't do anything. It's yeah.
Thank you.
Okay, right. Coming into the images, again you can appreciate global volume loss more in the supratemporal brain parenchyma as compared to the posterior fossa. So generalized reduction in the brain volume. The basal ganglia appear normal. Thalami, if you see on the third image, demonstrate normal volume. What was the age? 1 year. So yeah, nothing on the flare in terms of white matter changes. SWI, I do not pick up any abnormalities. Diffusion, again, no restricted diffusion. T1 sagittal demonstrates reduced volume of the corpus callosum in keeping with generalized reduction in the brain volume. The midbrain is slightly reduced in volume. Posterior fossa cerebellum and the vermis is actually appears normal. I cannot appreciate any cortical malformations per se given these single images. They're not suitable, but so generalized atrophy more in the supratemporal brain. Again, differentials are discussed in our previous case. These would be the differentials. And given the finding of megaloblastic anemia, these are the possible differentials clinically to rule out for megaloblastic anemia. B12 deficiency, folate metabolism disorders, cobalamin-related disorders can present with generalized atrophy. And also, if the child is on anticonvulsants, they can also present with generalized atrophy. But I think what was the time frame, Dr. Kamte, between the treatment and scan?
No, this child was like in the first scan done without any AEDs. Like child presented was directly.
Okay.
So
it's not. Yeah. Okay.
Yeah.
So do we attribute the changes primarily to B12 deficiency? If anyone wants to comment on the other possibilities, the case is open for discussion.
Any access to that upper spine? I saw your spine had like a sagittal image with no other spine images. Was there any other? Can you look at that?
Spine.
No.
Spine wasn't done. Only a brain was. Just
on sagittal, that posterior portion of that spinal cord.
Yes.
We just want kind of an edge of it there. Yeah, but yeah, it looks like B12 or any of the others on the differential that would be. But B12 we want to exclude, obviously, which you have done, and then the other ones would be an exclusion. And methylmalonate was normal, right? Yeah, it was subsequently. That's the best marker you have for B12. So, yeah, I can't think of anything else, but the atrophy is very pronounced.
Yeah. Dr. Kamte, if you remember, at least I remember cases where there was reversible atrophy post-treatment.
We have demonstrated reversibility after about 6 months now. They do a repeat scan. It almost fills up actually.
Okay, if there are no further comments, we'll move on to our next case. Again, Dr. Kamte.
Yeah. This is a 24-year-old gentleman who presented with symptoms starting from early childhood. This child was born to married couple, had mild development delay. He spoke after 2 years of age. He had issues of hyperactivity and poor performance. He was evaluated at the age of 4 years and diagnosed as mild intellectual disability ADHD. However, with special attention, he could complete his 10th standard. His symptoms actually started for the last 4 to 5 years. Parents noted he was slow in his activities. He developed frequent falls and imbalance while walking. Initially, he could even take his bike to the college, but now for last 3-4 years, he could not use his bike also. He is very slow in his walking and has frequent falls. For last 2 years, they even noticed reduced word output, and he had episodic aggressive behavior and had developed tremors in the hand for the last 2 years. He is now needing help for activities of daily living, and parents have noted a few myoclonic jerks in the last 6 months. He also had confusion irrelevant talking for the last 6 months. On examination, there was no dysmorphism. He had coarse tremors in the hand, and he had mask-like faces with Parkinsonian features. We are outside the beta glutamate enzyme was done, which is negative, and even LSD gene panel was done, which was negative.
Okay.
Okay, show the MRI.
Yeah. So the onset is from childhood, not adult onset.
Yeah, this child actually had symptoms of mild ID with ADHD starting from 2 years of age.
Okay.
But for the last 5 years, there has been what we call slow decline.
Okay. Here we have the MR images. On top is the T2-weighted sequences. Again, there is a generalized volume loss of the supratemporal and the infratemporal brain. The basal ganglia actually are not as clearly appreciable as we see on normal T2-weighted sequences. If you come lower down, the global pallidi demonstrate these T2 hypointensities, possibly also in the putamen. There is a periventricular addition, but I don't think it is significant. On the flare, again, the basal ganglia are not clearly appreciated. Again, some hypointense changes in the deep brain nuclei, predominantly in the global pallidi. If you come down to the T1 weighted sequences, at least I felt the entire cerebral parenchyma, at least the subcortical cortical regions, if you see over here, demonstrate these T1 hyperintensities. It's slightly more than what we normally see. And if you see the deep brain nuclei, that is the basal ganglia and the thalamus, and also the occipital region, again, there is some hyperintensity. Even in the sputum of the corpus callosum, there's a generalized T1 hyperintensity. The midbrain also demonstrates some hyperintense foci. And if you appreciate on the cerebellum, again, these are non-contrast T1 weighted sequences. The cerebellum also demonstrates some areas of T1 hyperintensity. On the SAG, the vermis is slightly hypoplastic. The corpus callosum is normal in volume. There's some reduction in volume of the midbrain. The diffusion weighted sequences, I am not able to ascertain what is the cause of the changes of the ADC sequences, especially on the diffusion. SWI, there was the images overlapped with the artifacts of the frontal sinus and the masseter cells, but I'm not sure if this is artifactual or not. But yeah, there is a areas of hypointensity on the right basal ganglia. The midbrain do not demonstrate a significant blooming foci, especially given the age of 24 years. Spectroscopy, again, slightly reduced NA peak, if Sanjay wants to comment on that, and the rest of the peaks also appear to be reduced. Just list out the possible differentials. Given the T1 hyperintensities in the basal ganglia, the diffuse involvement, these are the possibilities. Hypermagnesemia disorders, Wilson's disease, and since we have cerebellar atrophy along with cerebral atrophy, again, these are a list of disorders which can be excluded or ruled out based on the imaging findings. These are again cases of hypermagnesemia. You can appreciate that the deep brain nuclei are demonstrating T1 hyperintensity, but also the white matter in the generalized brain parenchyma demonstrates a slightly increased T1 hyperintensity. The NBI spectrum to be considered, but I'm not sure of the SWI changes. As far as you know, the cerebellar atrophy pattern can be seen in neuroaxonal dystrophy, and in the adult onset PLA2G or the plan mutation have features of no iron deposition on the SWI images, but these are only for the adult onset Parkinsonism phenotype cases. So at this moment, I'll open the case for further comments from the panelists.
Yeah, mineralization seems to be the most likely explanation, and your ADC is probably because even in manganese deposition, you can have some iron thrown in there, so you can have that ADC changes, and the SWI can be explained from that. It's not pure magnesium, pure manganese rather. I've seen this in patients who are on TPN and have nutrition issues. We actually have manganese deficiency, and you see this kind of change. So I think that and Wilson's would be the two. Your post tremors, everything kind of fits with that. And I agree that NBI iron deposition disorders would be less likely. But your first list, I think, where you had the manganese and Wilson's would be number 1 and 2, and SLCs obviously. But that would be the list we look at. The other ones is a much more broad list, and you don't see any of those other features as such. The basal ganglia changes, any of the things in the other lists are less likely. And I don't think NA is very reduced here, frankly, because in that basal ganglia region, the NA is pretty decent. So I think that spectrum is not diagnostic in this particular case.
Just to add, I think Dr. Kamte has a genetic diagnosis. I'm not sure if it's pathogenic.
Yeah, we sent a hologram for this child. It showed a homozygous autosomal recessive likely pathogenic mutation in PLA2G6, registry of plan, NBI 2B. So it was like a surprise actually.
Yes,
with this identical case, we did not think of plan, but it showed a autosomal recessive likely pathogenic mutation. So most likely it is NBA type 2B.
Good case. As I said, it's less likely, but that's the one which came out. So but it's in the differential, you know. Treatment for this? How do you treat this thing? Can you do anything else, or symptomatic treatment? Nothing, right?
It's just symptomatic. As of now, nothing.
Yeah.
All right. Thank you. Dr. Vivek, we have a follow-up case. Do you want to quickly go through it?
Yeah, this patient we discussed a few weeks back. So, 6-week-old baby who had seizures from 3 weeks age, significantly delayed. So more like a developmental and epileptic encephalopathy, frequent seizures, and also had bilateral cataract. Sibling died with a similar history, though family was not aware if she had cataract, but she had a lot of seizures. And our workup, sort of basic workup, was normal, and we discussed the MRI, which we thought had hypomyelination, but I'm really grateful to you and Dr. Balthauser and Krish and everybody else. They mentioned is dysmyelination with temporal cyst. So we informed the geneticist to look specifically for vanishing white matter disease, and it did come out with it. So he had vanishing white matter disease. So just the cataract is something which was unusual, but then again, Dr. Balthauser told that it was seen in one of his patients.
Yeah. Thank you for the follow-up, Dr. Vivek. I think cataract was also mentioned as a possibility for vanishing white matter by Dr. Balthauser. And actually, these are his cases, which was sent to Dr. Vandana in her book. These are infantile neonatal cases. Again, you have similar appearance to what we have seen in our case. The refractory, diffuse swollen refractory appearance of the cerebral brain parenchyma. So as seen in our case, what was the age? 45 days. Okay.
Yeah.
Sanjay, you want to add anything to it?
Nope. Looks
okay, right? Yeah.
Good case.
Thank you. Case 11 is another follow-up. So this was an 8-year-old child with global developmental delay, febrile and afebrile seizures, and was operated for squint. There were questionable signs, cerebellar signs. I think we discussed this case 3 months back. So here we have the T2 sequences, and you can appreciate this diffuse extensive areas of cortical malformation in the form of Cobblestone malformation, abnormal subcortical intracortical areas of hyperintense foci, which are typically seen in the Cobblestone spectrum. They are slightly dysmorphic lateral ventricles. Basal ganglia are relatively normal. Corpus callosum is again dysplastic. Brainstem is again dysmorphic and hypoplastic. The vermis is abnormal, and there are tiny cysts, especially in the bilateral inferior cerebellar hemisphere in the subcortical regions. And the lens also opacified, so I'm not sure if this is a post-operative case or a child had the cataract. Again, similar changes on the T1 weighted sequences. Angiography did not demonstrate any abnormality. So at that point, we thought possibilities of ADGRG1 given the supratentorial and infratentorial changes of diffuse cortical malformation, dysplastic corpus callosum, abnormal brainstem and cerebellum with cerebellar cysts. So the differentials for Cobblestone malformations are congenital muscular dystrophies and other genes such as FOL3A1, GPR56, which is now ADGRG1, LAMA2, LAMB1, LAMC3, and TM2C3. Again, differentials for cerebellar cysts, as we have seen in the previous panel. COL3A1 can also present with similar changes. And these are the imaging features of the Poeti-Bolthauser syndrome. Characteristically, they have relatively less common, or they usually don't have supratentorial brain malformations, but they have cerebellar cysts and this abnormal dysmorphic lateral ventricle. It's almost like a 10-shaped lateral ventricle. And the clinical presentation is slightly different, with a common presentation of oculomotor apraxia and myopia in these cases. So this child, the genetic workup came out to be a variant of uncertain significance, but I think the imaging and the clinical point of view usually matches with this gene. I don't think we have Dr. Ramesh, but if anyone wants to comment on the imaging or the clinical presentation, that would be great.
I think Kish and I have discussed this before in another forum with the Cobblestone multidisciplinary and polymacrogyria and the overlap between the two. This looks like Cobblestone dyscencephaly and the cerebellum. I think in addition to the cysts, I think there's some there's actually cortical malformation. That actually is Cobblestone in the cerebellum as well, and the PIA is affected. I think I have one more case like this, which is just looks like this, but it was another mutation. I need to find it, but only one case which would look like this, but was not it. Almost every case that we've seen which looks like this is almost GPR56. It's quite pathognomonic looking. But the lens thing is interesting. I haven't seen this in my patients. Need to go back and look again. I don't know whether that's a feature, because then you would raise the other Cobblestone lyssencephaly spectrum with the eye changes and muscle changes and stuff like that. So that's the other different thing to think about.
All right. Okay. Thank you. Dr. Vivek, another follow-up?
This one, when I put for follow-ups, I thought I had the diagnosis, but I don't still. So a few leads. So I don't know whether I should still mention. So it's so the child is 18 months old now, and always had a small head, antenatal small head. At 11 months, performing like a 7-month-old, so mild delay, and deteriorated at 9 months age suddenly, and got admitted in a local hospital for 6 weeks and started to have frequent sequential and migratory seizures from either side. She had pericardial effusion. That was at 11-month age. And then I started to see her. Now she's around 19 months. And over the last 8 months, she has significantly regressed. We had shown some videos as well last time where she now has a movement disorder, significant This was when she was sort of normal. So this is when she was normal. Normal as at 11 months, like a 7-8-month-old, sitting and so, but not exactly normal, but delayed, but and the small head. So that's the one. Then next videos. Yeah, this is the first video, shows her seizures. The first one, she becomes hypomotor and then a slight uprolling of eyes. That we were not sure whether it was ocular gyria with hypomotor events or seizures. The first video, we were not sure. Second one, I think this one I remember was seizure. Yeah, this was seizure. Left-sided, she would have right side as well. So a movement disorder which had ocular gyria, hypomotor events, seizures, and the last video shows dyskinesia. I think that was dyskinesia. So that was myoclonus actually. The myoclonus, which was non-epileptic myoclonus, because we had an EEG done as well at the time. Glucose was normal, the ratio was normal. So we did a very extensive workup at the time. Over the last 8 months, while she has been being followed up, the problem has been that she initial MRI maybe shows simplified viral pattern. It now shows atrophy. So we think there's a progressive disorder. She has had pericardial effusion twice, and she has anti-Rho antibody positive, ANA significantly positive. So we have a child who has neuroregressed with movement disorder with epilepsy, with some autoimmune markers being positive. So whole exome sequencing trio initially was normal, microarray was normal. So I did several CSF neurotransmitters because of this movement disorder. So she had a very low folate. So 3, normal should be more than 60. So at that time I had put it, the case I put it, okay, I had the lead, this is cerebral folate deficiency, and now we have the diagnosis. So that was what I thought. So then we gave her leucovorin, but that didn't really help much. And we still couldn't explain her antibodies. I was looking through the causes of cerebral folate deficiency. There are only 3 which are seen with such low folates. One is there is a problem with the receptor, folate receptor, a genetic defect. Second is an antibody to the receptor, and third is Kern-Sire syndrome. So these are the only 3 causes of very low folate. And she had a very high CSF protein of more than 150. So I thought maybe it's Kern-Sire, and because we gave her leucovorin, it didn't help. Folate antibodies we cannot do in India. That's done in America and they charge a lot, so we couldn't do it. But then again, the treatment for that is also leucovorin. So over a few weeks, it didn't help. Kern-Sire was normal testing. So we didn't have a lead. So we have a child and the autoantibodies were still strongly positive and no response to steroid and immunoglobulins. So we then thought this could be a type 1 interferonopathy, a genetic interferonopathy. So what happens if you have a genetic defect? There is a excess interleukin response which causes all these problems, which is similar to neurotransmitter disorder. So we asked the MedGenome team to reanalyze the whole exome for interferonopathies, but that was negative. But then they found a gene which was positive for a disorder which causes microcephaly with chorioretinopathy. She doesn't have retinal involvement, but there is a compound heterozygous mutation in it. So, but that's still that I think that gene I cannot even properly. I did mention it in the
G6.
What was it? TUB-G6. Yeah,
TUB-G6
TUB-G6 space. So I read about it. Not much is given in the literature, but it does fit in with her small head. It doesn't explain her antibodies. So not sure, but it is a compound heterozygous mutation. And her face is like, and no correlator. Yeah, but there are so few cases one doesn't know if that is essential. But there is a deletion on one of the chromosome, the other one is a missense mutation. So deletion becomes very important. So there's a compound heterozygous mutation. So not sure, but a child who has a very slow CSF folate with the antibodies in the blood, and this gene is positive. So maybe in future, maybe if I get an answer, I will put it up again. But if there's any other thoughts, be more than happy to discuss.
Yeah.
The microcephaly at onset is what's interesting. Like if you had any of the other acquired things, you expect the child to be initially normal. At 11 months, you have like a microcephaly already. So that makes more sense. And maybe a secondary thing, which is I can't explain your antibodies, but the microcephaly seems to be at onset, even when the child looks relatively normal, the head small. So this is a process which started off and maybe progressed with a secondary event. Maybe that's the most likely explanation. Any anticonvulsants or anything which could have affected the antibody profile, anything that's any medications, etc., which can affect that antibody profile?
So yeah, so she did receive anti-tubercular treatment for a few months for pericardial effusion, but her antihistone is not positive. That's the one which becomes positive with tuberculosis. So no medication which could explain it.
Yeah, interesting. I think there's still simplified gyri. The gyri don't look normal, even if it's for atrophy. I think there is some simplification of gyri, which is also something to consider. The cerebellum looks relatively normal, and that's coronal. Normal cerebellum and very simplified looking gyri with atrophy thrown on top of it.
It's just we often see patients with microcephaly, simplified gyral pattern. They have delay, they have occasional seizures, but they don't develop over just few months such progressive atrophy. So there must be a process, which is whether primary or a second illness is just by dictum you try to knit up everything in one disease, which we cannot.
The only thing I've seen is epileptic encephalopathies in a patient with microcephaly. I think I remember at least one patient like that, where there was severe atrophy and the child seized continuously. There was no way we could control it. And there you had significant atrophy. But his epileptic encephalopathy is undiagnosed and the child actually passed away. So
Yeah.
that's one explanation.
So she has had multiple video EEGs. She does have seizures, but they're not like epileptic. So they're like once every few days, and her EEGs, hours of EEGs don't show. So occasional discharges. The child is not in epileptic encephalopathy.
Okay.
So maybe watch the space. We'll see.
Yeah. All right. We'll move on to our last case for today. I think this is also a follow-up, which was discussed, I think, in the last session. Romit, if you're there, you can probably give a brief outlay of the case.
Yes, sir. So this was a case of an 8-year-old boy who presented to us with acute febrile illness, episode of gastroenteritis, was treated with IV antibiotics for some period, and then he developed slowly progressive quadriplegic spasticity, painless loss of vision, and on examination at 1.5 to 2 months into the illness, he presented to us, had severe spasticity, no perception of light, and CSF, initial CSF that we did was normal. We didn't send oligochronogens, we just sent NMO mock that turned out to be negative. And the MRI, if you can see.
Yeah. Do you want to comment on the EEG?
Yeah, actually it was after Dr. Vijay sir flagged the possibility of diagnosis.
Okay.
So
Okay.
the EEG.
So these are the MR. Okay. The MR images again here. The diffusion we could see some areas of hyperintense foci in the bilateral frontal regions and especially in the left frontal region, extending up to the splenium of the corpus callosum and the occipital regions on the left. The bilateral cerebellar peduncle also demonstrated this hyperintense foci or restricted diffusion. There was a generalized volume loss in the supra and infratemporal vein, though I don't have the images of more on the supratental vein parenchyma, but you can appreciate the abnormal white matter lesions in the sagittal images in the frontal and the parietal regions. Clear again, you can see that the white matter is not as clearly dark as one would expect in a normal scan. It is slightly smudgy and there's hyperintense changes in the white matter. The ventral aspect of the brainstem also demonstrated the sliding of hyperintensity. And again, FLAIR demonstrates its symmetrical foci of hyperintense changes. So the spine was done. There was a equivocal appearance of hyperintensity on the sagittal images, but on the axils, you can appreciate that there is this central area or transverse area of hyperintensity. This is the axial section of the cervical cord. Post contrast, we could not appreciate any enhancement. There was a follow-up scan, and the changes have actually progressed. The ADC sequence are now more darker than previously seen. There's a progression in the lesion, and also there is generalized atrophy. Again, the posterior fossa changes were similar to what we have seen in our previous study. So at that point, we thought of possible splenial lesions, demyelination, and probably focusing on the splenium or the posterior aspect of the cerebral white matter. These were the possible differentials noted. Given the cerebellar or the cerebellar white matter involvement, again, these possibilities, but the supratemporal changes would not match in few of these cases. Encephalitis was an unlikely possibility. And then post MRI, we had the EEG, which Romit will describe.
Yes, it was basically a progressive illness, and there was a discussion about it being a autoimmune process versus something else. So once the possibility of SS was flagged, but child didn't have any clinical myoclonus or seizures, so we did an EEG, which is quite characteristic, very high amplitude generalized low spike wave complexes, we can see. And on the second EEG, it's basically a compressed EEG, which shows sort of pseudo-periodic discharges. So it is quite characteristic of SSPE. So we did send a CSF measles antibodies that came out to be positive.
Right.
SSPE again, histologically is demyelinating in nature according to the literature, right? Is that correct, Nihaal? Did you check on that? What exactly
Yeah,
does it?
it's a demyelinating chronic. It's a chronic inflammatory demyelinating process.
Interesting, right? So many things are demyelinating, but they have different manifestations.
Yeah.
So in the
EEG
acute
wasn't
setting, you qualify for ADEM, right? In the acute setting, you had an acute, you had a demyelinating encephalomyelitis, basically. But this was a discussion last time, and the diffusion changes were a bit weird.
Yeah.
Persisting. But yeah, SSPE and measles, common things being common out there, right?
Nihaal, we should make a list of disorders where the EEG trumps the MRI. I've written at least a few cases like POLG 3 as well, where you have the characteristic EEG patterns, where the EEG recognition can trump the MRI pattern recognition. One of those.
I can give you another condition if you're trying to write that up, then that's molybdenum cofactor. Apparently the EEG feels strike. Thanks for the feedback, Nihaal, again.
Thanks, Romit. And I think that's our last case. So we'll have a session on 8th April next time, and I'd like to thank the panelists, Dr. Mankad, Dr. Kamte, and Sanjay. Nice to see you.
Thank you.
Thank you. See you in 2 weeks, chat. Thanks. Bye-bye.
Yeah, bye. Good night.